Hello, everybody. We want to welcome you to today's webinar, Understanding the Early and Periodic Screening, Diagnostic, and Treatment Benefit. We're really excited you all could join us, and thank you for taking the time to participate in today's webinar. We want to wish you all a Happy New Year. We're excited to have this to kick off our content for the Healthy Students Promising Futures Learning Collaborative for 2019. My name is Alex Mays, and I'm the National Program Director for Healthy Schools Campaign. And Healthy Schools Campaign has the pleasure of co-convening today's webinar with Trust for America's Health. Healthy Schools Campaign and Trust for America's Health co-lead the Healthy Students Promising Futures Learning Collaborative. And I know the majority of folks on today's webinar are members of the Learning Collaborative, so we really appreciate you all joining today. And for those of you who aren't members of the Learning Collaborative, we'll take a few minutes in a moment to give a quick overview of the Learning Collaborative just to orient everybody. Next slide, please. So today's webinar is going to run for an hour, and we will have a recording of the webinar available as well as the slides from today. And we'll be sending those out by the end of the week. So look out for an email with those links coming probably most likely on Thursday or Friday. We will also be saving time at the end of the webinar for questions and answers. So throughout the webinar, please feel free to send in your questions using the questions box, which is in your control panel, which should be on the right-hand side of your screen. So just send those in as they come to mind, and then we'll be collecting them and asking them of the presenters today. Next slide, please. So again, I just want to thank the supporters of our Learning Collaborative who make the Learning Collaborative possible, in addition to being able to share great content like this webinar with you today. The supporters are listed up here, so we want to thank them all for their ongoing support of this work. Next slide, please. So just very briefly, for those of you who might be new to the Healthy Students Promising Futures Learning Collaborative, this is an effort that, as I mentioned, is co-led by Trust for America's Health and Healthy Schools Campaign that's been taking place for about 2.5 years. And it brings together states with the goal of supporting increased access to school health services through Medicaid reimbursement. And it was actually launched 2.5 years ago by the U.S. Departments of Education and Health and Human Services, really out of the recognition of the need for states and school districts to have a space to come together for peer-to-peer learning, to strategize around ways in which they could leverage new opportunities in health and education to support expanded access to health services through Medicaid reimbursement. And Healthy Schools Campaign and Trust for America's Health actually took over leadership of the effort about 2 years ago and are thrilled to be continuing this work and plan to do so for the foreseeable future. On the next slide, you'll just see we have 15 states that are participating in the Learning Collaborative. And what that means is that participating states create state teams that include representatives from their state education agency, their state Medicaid agency, and at least 2 school districts. And then many of the states have additional team members that participate on their state teams, including representatives from public health, advocates, multiple representatives from some of those agencies I mentioned earlier. So just a really nice mix of folks at the state and local level who are really committed towards identifying ways in which we can expand access to health services. So we're really thrilled to be doing today's webinar, which is a part of the 2019 content for the Learning Collaborative. Next slide. The Learning Collaborative does in-person meetings, but then we also do a host of content throughout the year through webinars and calls with leaders and case studies and whatnot. So if you aren't already participating in the Learning Collaborative and are interested in learning more of questions, please don't hesitate to reach out. And so as I mentioned, today's webinar is really going to dig into the early and periodic screening, diagnostic, and treatment benefit, or EPSDT, as it'll be referred to throughout the webinar today. And as you all know, Medicaid covers essential services for healthy children, such as screening for medical, dental, vision, and hearing problems, as well as treatment needed to correct or address the problems discovered during those screenings. And that's done through the EPSDT benefit. And there's been, this is an issue that is, continues to come up through the Learning Collaborative. And so we really wanted to take the time today to provide a 101 around EPSDT to ground everyone in this critical program that really supports the health of kids across the country. Every state has an EPSDT program. They look a little different in each state. In Illinois, it's called Healthy Kids. In Minnesota, it's Child and Teen Checkup. In Texas, it's Health Steps. In Connecticut, it's Pathways. And while they look a little different in each state, the core program is the same, and it's really what makes Medicaid such great coverage for kids. And it's specifically targeted to help kids get all the services that they need. Screenings are delivered to Medicaid-eligible kids on a certain schedule, and the screenings can be provided when a problem is suspected, and a parent, teacher, provider can recommend a screening. And then medically necessary treatment is covered as well, including medical services, mental health services, services like speech or occupational therapy, dental services, glasses, hearing aids, etc. So it's a really comprehensive program, but we recognize it's a little bit complicated to understand, which is why we're thrilled to have CMS with us today to share more about it. You're all here today because you know EPSDT can really play a big role in how Medicaid enrolled students get the behavioral health and medical services that they need, both in communities and in schools. Many school districts are using Medicaid EPSDT funding to provide screenings and services to kids, but the restrictions on how these funds can be used can be really confusing and complicated, even for the most experienced school leaders. So on this webinar today, we're excited to be digging in more with CMS's two experts on the EPSDT benefit to talk to us about what EPSDT is, how it works, and what the statutory requirements are. And as with all things Medicaid, states play a big part in how the EPSDT benefit is implemented in your state. So we really hope that this webinar will provide a grounding in the federal piece so that you'll be able to better understand your individual state landscape. So next slide. So we are thrilled to have Lindsay Wild and Marguerite from CMS joining us today. Lindsay is one of the analysts in the Division of Benefits and Coverage with the Disabled and Elderly Health Programs Group in Medicaid. And as an analyst, she's responsible for the review of Medicaid state plan amendments under the Rehabilitative Services, Preventive Services, and other licensed practitioners benefits. And Marguerite is one of the technical directors in the Division of Benefits and Coverage within the Disabled and Elderly Health Programs Group in Medicaid as well. Her team is responsible for the review of Medicaid state plan amendments under the Rehabilitative Services, Preventive Services, and other licensed practitioners benefits, and also for several policy areas, including substance use disorder treatment services, maternal depression, home visiting services, and the Institution for Mental Diseases and inmate Medicaid exclusions. So we are thrilled to have both Lindsay and Marguerite here with us today. Lindsay is going to present on the slides that follow this slide, and then both Lindsay and Marguerite will be available for the question and answer session that will follow. So next slide, and I will now hand it over to Lindsay to take us through the slide presentation. Thank you so much for joining us, Lindsay.
Wonderful. Thank you so much, Alex. And hello, everyone, and good afternoon, good morning, depending on where you're located. As Alex mentioned, my name is Lindsay Wild, and I'm an analyst in Medicaid's Division of Benefits and Coverage. And I'm joined by my colleague, Marguerite Shervich, who is our technical director in the same division. And today we'll be discussing the early and periodic screening and diagnostic and treatment benefit with you, also commonly known as EPSDT. We'll be talking through the EPSDT slides that we have here, and then upon completion of the slides, we will have time for a question and answer session. So if you have any questions along the way about any of the slides, please feel free to type it into the webinar chat box for that later question and answer session. Next slide. To start us off, generally the Medicaid program is administered by each state according to broad federal requirements. So the Medicaid program contains a wide array of mandatory and optional benefits located in Section 1905A of the Social Security Act. And each state has a Medicaid state plan, which is a document that describes how their state administers the Medicaid program and lists the services provided. So each state does it a little bit differently, but the Medicaid state plan is where all the services are listed that are in the Medicaid program. Next slide. So let's discuss what EPSDT is as a benefit. So it's a mandatory benefit for most individuals under the age of 21. EPSDT is a benefit, not an eligibility option or program. The acronym EPSDT is used to mean well child visits as well as necessary treatment services under 1905A of the Social Security Act. And the ultimate goal of EPSDT is really to provide the right care to the right child at the right time and in the right setting. Next slide, please. So why do we have EPSDT? The EPSDT benefit was authorized in 1967 to ensure that children receive the medically necessary services they require in alignment with the right care to the right child at the right time in the right setting goal of EPSDT. And in 1989, the statute changed the language from may provide other 1905A services to must provide 1905A services in an effort to more firmly reinforce the assurance of children receiving the medically necessary services they require. Next slide, please. In accordance with the EPSDT requirements, states must establish a distinct periodicity schedule for screenings or well child visits, vision, hearing, and dental services. States have the option to adopt national periodicity schedules, such as Bright Futures, for implementation within their state. And on the next few slides, we'll be discussing screening, again, also known as well child visits, vision, hearing, and dental services a little bit further, and we'll be walking through what each component of the acronym EPSDT really means. Next slide, please. So first, under EPSDT, we have early and periodic screening. But what does that mean? Under 1905R of the Social Security Act, which is the statute setting forth EPSDT requirements, screening services consist of comprehensive health and developmental history, comprehensive unclosed physical, appropriate immunizations according to the Advisory Committee on Immunization Practices, laboratory tests, including blood tests, and health education. Next slide, please. In addition to screening services, states should ensure that all medically necessary vision, dental, and hearing services are provided to children under the age of 21 in accordance with the EPSDT benefit. In addition, as mentioned previously, states need to have in place periodicity schedules for screening, vision, dental, and hearing to ensure that children are receiving medically necessary care from infancy through adolescence. Next slide, please. Under EPSDT, the D stands for Diagnostic Services, and Diagnostic Services are when a screening examination indicates the need for further evaluation of a child's health. The child should appropriately be referred for diagnosis without delay. And that covers a lot of different services, so it's a pretty all-encompassing area to cover. Next slide, please. And finally, under EPSDT, the T stands for treatment. So EPSDT requires the provision of all medically necessary services listed in Section 1905A of the Social Security Act. And this is important, whether the state covers these services for adults or not. So again, the ultimate goal is for children to receive the right services that are medically necessary for them, whether or not the state offers them for adults. Treatment services also include services that maintain or improve the child's current health and condition and are required by EPSDT, and services that can ameliorate a condition, but it does not necessarily have to cure a condition. Next slide, please. And there's been a lot of discussion on the previous slides thus far about medically necessary services. So this slide is a complete list of the mandatory and optional benefits from which services should be made available to children under the age of 21 in accordance with EPSDT. And this slide lists all the 1905A services of the Social Security Act that are listed there. Next slide, please. In addition, there has been a lot of reference made thus far to medical necessity. But what does that mean? So medical necessity is determined on an individualized basis, taking into account the individual's needs. There are services that fit within the scope of coverage under EPSDT and must be provided to children only if necessary to correct or ameliorate an individual child's physical or mental condition, again, only if medically necessary. The determination of whether a service is medically necessary for an individual child must be made on a case-by-case basis, taking into account the particular needs of the child. Services to children can't have what are called hard limitations, or limitations that cannot be exceeded based on medical necessity, because the state has to make available all medically necessary services. States, however, may use prior authorization processes to ensure what are called soft limits, or limitations that can be exceeded based on medical necessity are in place for the services. But all medically necessary services should be made available to EPSDT children under the age of 21. And finally, CMS does not set medically necessary criteria for the Medicaid program, and therefore, again, each state creates a medical necessity criteria for their state, so each state has the flexibility to have their program structured a little bit differently than other states when it comes to medical necessity criteria. Next slide, please. In continuing with our discussion of medical necessity, EPSDT does not require coverage of experimental treatments or items. These items may be covered at the state's discretion if effective to address the child's condition. EPSDT does also not require coverage of services or items not generally accepted as effective or services for caregivers' convenience. States may consider the relative cost effectiveness of alternatives as part of the authorization process. And children age out of the EPSDT benefit at the age of 21. So again, EPSDT services are for those children younger than 21 years old. Next slide, please. And this slide discusses managed care and EPSDT services. So all EPSDT requirements must be adhered to, regardless of the delivery system. The state is responsible for medical necessary services not included in the managed care contract, and 42 CFR 438.10 requires managed care organizations to provide informing materials to beneficiaries and enrollees on how to access benefits not covered under the managed care contract. Next slide, please. And when it comes to EPSDT, to finding EPSDT services in your state's Medicaid state plan, the services can either be placed under item 4B, as in beta, which is the EPSDT benefit section of the Medicaid state plan, or the services may be under each specific 1905A benefit category within the state plan. All EPSDT services must have a reimbursement methodology in the Medicaid state plan, and EPSDT requires a reimbursement methodology. So if you're looking for a specific service and you can't find it on the coverage pages, it might be worth checking the 419B reimbursement pages of the state plan to see if the service is listed there. All right, next slide, please. So this slide provides some EPSDT resources regarding EPSDT and the Medicaid state plan, and the CMS informational bulletin on EPSDT as it relates to managed care. Next slide, please. And thank you all for your attentiveness during the presentation. And before I open up the discussion for questions and answers, I wanted to note that if you have any EPSDT related questions after this presentation, or if an EPSDT related question comes up in the future, CMS has a designated email address for EPSDT related questions, and I provided it on the slide. It's epsdt@cms.hhs.gov. And I wanted to thank you all again. And at this time, I'd like to open the floor for any EPSDT questions that you may have.
Great. Thank you so much, Lindsay. So please send in your questions through the questions box in the control panel. We've had a few come in, so I'll go ahead and get started with those, but just feel free to keep on sending them in. So Lindsay, and then I know Marguerite is on as well, who's Lindsay's colleague. Could you speak a little bit more about what EPSDT really could look like in a school setting?
Sure. So this is Lindsay, and I'll start, and Marguerite, please jump in. So EPSDT in a school setting, it could take a multitude of different forms. It's kind of up to the state Medicaid agency and how they want to structure it and what services they want to propose under school-based services. So that said, to go back to the slide in my presentation where it has listed all the 1905A Medicaid services, that's all of the options that the state Medicaid agency could use to combine to create a school-based services program. So there is flexibility at the state level to determine what services they would like to offer in schools. So the answer is that it depends a little bit based on which state you're in, but that it can take many avenues and look very different depending on what state you're in.
Hi, this is Marguerite. I think one of the key things to remember about EPSDT services in schools is that the primary, I guess, tenet of services in schools is that schools can provide and cover any Medicaid coverable service to a Medicaid eligible beneficiary by a qualified provider. And that's essentially the new twist on what formerly was known as the free care policy. In the past, we said Medicaid could not be billed for services that other beneficiaries would not be charged. We've withdrawn that policy back in December 2014. So in keeping with what Lindsay was talking about, any medically necessary 1905A service could potentially be offered by a school in the school setting to that Medicaid eligible beneficiary by a Medicaid qualified provider. Sometimes states only want to keep it to the services in an individualized education plan. That's okay. Sometimes schools want to do, add to that a Section 504 plan, services in a 504 plan. But they also have to be sure that they are covering then any other medically necessary service. If they come in and decide that they want to broaden beyond an IEP, then they have to also cover any medically necessary service. Now I'm going to stop right there because I probably said a boat full.
Great, thank you, Marguerite. And Lindsay, that's really helpful clarification. And I'm sure we'll generate some additional questions, which I will let come in. So then the next question for both of you is, can you speak to the differences for children covered by Medicaid EPSDT versus those that are part of the CHIP program? And this individual specifically said that they understand that the CHIP program, depending on the state, may not cover services that would have been covered for a Medicaid population. So I guess if you could clarify what this looks like for Medicaid versus CHIP, that would be helpful.
Sure. So this is Lindsay, and again, I'll start, and Marguerite, please jump in. So unfortunately, we don't have representation from CHIP on the phone with us today. I think in general, CHIP has more flexibility in terms of they cover things that the Medicaid state plan doesn't cover, as you mentioned, but the Medicaid state plan covers 1905A Social Security Act services. So I would say that the Medicaid state plan is used as kind of the baseline, and it covers the majority of services that you'll probably see, but then CHIP would extend it a little bit further to cover maybe a few more additions in addition to that.
And this is Marguerite, and I obviously we're not the CHIP expert, subject matter expert, so I would appreciate that being sent to us afterwards, and maybe we can get a CHIP person to opine on that for you.
We definitely will follow up with that and get additional information. Thank you. So next question, can you speak a little bit about how the state wraps around EPSDT services that are not covered in the MCO contract, and explain a little bit about how that works in practice?
Sure, this is Lindsay again. Unfortunately, our Division of Managed Care is also not on the phone with us. So we can take the question about CHIP and the managed care organizations back and provide follow-up responses once we are able to connect with those divisions.
Great, thank you for that.
Yeah, Marguerite, the only thing I can add to that is what is in the contract, obviously, the managed care plan has to offer. But that won't relieve the state of offering medically necessary services under EPSDT. So in a way that's not really wrapping around, but it's saying that what the MCO plan isn't covering, then the state must still make sure that EPSDT services that are medically necessary are furnished to a child. Beyond that, I'd be a little hesitant to talk about managed care. There's certain provisions in the contract that managed care plans have to abide by that fee-for-service wouldn't have to. For example, quality requirements, a quality strategy has to be developed. Quality reviews have to be done. Those are the things that come to mind. So I'm going to shush at that point again, and we can elaborate a little more. But I do know that this is one of those issues that keeps coming up, managed care versus fee-for-service. And I'm not myself fully appreciative of all the nuances, but I would appreciate your specific nuanced questions. We do work with someone you probably all know, Susan Ruiz is a very good resource, not only on managed care, but just on EPSDT. She's worked in that area for a number of years, so she probably understands the nuances better than me and Lindsay.
Thank you for that, Marguerite. We definitely will follow up and make sure and see if we can get some additional details on those questions. And I appreciate the specific recommendation for an individual. So next question is, do health screenings done in a school setting, such as vision, hearing, and learning, can they be reimbursed as a part of EPSDT?
Sure. So this is Lindsay. So yes, is the short answer. If the state has that listed under school-based services in their Medicaid state plan, then screening services, vision services, hearing services provided in the school setting would be able to be reimbursed for. It would, again, ultimately depend on if the state has listed it in their Medicaid state plan and has gotten approval from CMS. But conceivably, yes, that would be a coverable service.
And I would add that you'd want to make sure that the benefit category was appropriate. For example, you might want to consider the other licensed practitioner benefit and add nursing services, the services of a licensed nurse. That might be one way to go to add the screenings. Another way to go might be if you're going to do mental health screenings, you may want to have, for example, the licensed social worker be part of that be included in the OLP benefit. When I say included under the OLP benefit, don't forget Lindsay said that the school services can go under item 4B in your state plan, or it can go under the 1905A benefit. But if it goes under 4B, states still have to identify for us what is the Medicaid benefit. So under 4B, it would say something like services of a licensed nurse or services of a licensed social worker pursuant to the other licensed practitioner benefit, 1905A, is it 6? I think it's 6. And so we want the state to identify the benefit category even under 4B. Does that help? I hope.
Yes, that's very helpful. Thank you, Marguerite, for that clarification and the specifics. Great. So we've had a number of questions regarding providers who can offer EPSDT. So to summarize them, the question is what providers can provide EPSDT services in schools or outside of schools?
Sure. So this is Lindsay again. Under the Medicaid state plan, we have a requirement. It's called free choice of provider. And under that requirement, it states that any beneficiary can obtain services from any qualified Medicaid provider that undertakes to provide the services to them. So minimally, we would want the services in a school setting to be the same as services in a community setting or a non-school setting, so that students and children can receive the same services regardless of setting. And then up to beyond that, it would kind of depend on the services that are being proposed. So for example, rehabilitative services might need someone specialized in that, such as a psychologist. As opposed to screening services, you might use someone that's certified but not licensed. So it would depend a little bit on the services being proposed. But ultimately, beneficiaries can obtain services from any qualified Medicaid provider that chooses to undertake services to provide to them.
And this is Marguerite, and I would add a couple of points. It seems to come up fairly often when we get state plan amendments to review that the practitioners sometimes in the school setting might have, quote, lesser qualifications than a practitioner outside the school setting. And our basic standard is that any practitioner who furnishes services must meet the state's qualifications and any federal qualifications for furnishing that service. And they can't, services in a school setting cannot be, quote, less than services for that same practitioner outside the school setting. However, if a school, in the school setting, if there is some additional requirement, such as some additional training or experience, that is okay. It just can't be less than. And then there's this whole, I didn't even know about this, and I guess it's been around for 10 years, the whole issue about prescribing, ordering, and referring providers. They're in the requirements are in regulations at 42 CFR 455.410, and it goes on from there. And basically, school-based providers, if they are the prescribing, ordering, or referring provider, practitioner, I'm going to say, they have to meet the requirements in these regulations. And basically, the requirements are they have to be screened, and they have it's an anti-fraud measure. So they have to be screened and pass the screening that the state does, and they have to have a provider agreement and a Medicaid provider identification number. So that's for the prescribing, ordering, and referring providers. However, you've got the rendering providers, and those furnishing providers only have to meet the screening requirements. Any services that they render and for which the state claims must include the provider identification number of the physician or other professional who ordered, prescribed, or referred the items or services. So rendering practitioners are going to be the ones, probably the day-to-day folks that are doing the service, and either the school is going to be doing the billing, or probably the school is going to be doing the billing. But if there is some outside practitioner who has an NPI and who has done, has provided services, they can bill directly to the state. Or the prescribing, referring, or ordering provider might want to bill directly. But generally, I think schools are going to bill, and states have to make sure that any claims they send us include the NPI, the practitioner identification number of that practitioner who ordered or referred the items or services. Now, one last point, and then I'm done. Any practitioner qualifications must meet the state and federal regulatory, statutory, or guidance requirements. What often happens is there's questions around the therapies. So therapies under 42 CFR 440.110, those are our requirements. Those are federal requirements. So a PT or an OT or a speech pathologist or an audiologist have to meet the requirements in our federal regulation, not just any state requirements. And that one, I think we frequently hear about that issue from states.
Great, thank you for that, Marguerite. That's really helpful, and we appreciate the additional detail on that one. So the next question is regarding duplication of services. So are there any federal guardrails around duplicative delivery of EPSDT and billing in multiple settings, such as school settings and pediatric offices?
Sure. So this is Lindsay, and I'll start. Again, Marguerite, jump in. We do have another separate division that works on reimbursement specifically, but I mean, ultimately, we want to not have duplicative services billed for. So the goal is not to have services be billed for in the school and then in a different setting.
Yeah, I'm afraid you are absolutely right. Whoever said there can't be duplication of services, but but I'm not exactly sure why there would be duplication of services, but that is a reimbursement question. I believe, and this is going out on outside of my knowledge base, but I believe that state Medicaid programs have a way to, the word they often use is edit. They put an edit to make sure that a certain beneficiary isn't receiving the same service at the same time. Now, what if a child goes to school and then has the same service after school? I don't know what would happen with that claim. I would think that since it's a different provider and it's a different time of day, my guess would be you're not duplicating the same service. In the school setting, the service is helping the child benefit from the school and the educational environment and education, whereas in the community setting, the focus may be different in helping the child. Let's say it's physical therapy or occupational therapy. It may be helping the child ambulate around their community or helping them in their environmental orientation in the community versus how do they benefit from their education. So if we can also take that back. There's one more thing I do want to add that we are not the experts on. Third-party liability requirements, those do have to be met. And while I was thinking of reimbursement, I thought of that. So I just want to mention that that I think we've come to the conclusion that if there is a third party out there, like another insurance plan, that the state still has to bill that other insurance plan. Under an IEP, Medicaid can pay first. But if services are not under an IEP, Medicaid is typically the payer of last resort. So, and then any other insurance company would also have to be billed. So that's it in a nutshell, but there's some nuances to that, which I have in our full files, but I haven't looked at recently. So I can, if you remind me of that question, I can pull that out too.
Thank you, Marguerite. Yes, I'm sorry, just to clarify on the third-party liability piece, that would just be for students who have dual coverage, correct? Who are covered by Medicaid and private insurance, right?
It would be any other, could be workers. Well, I don't know whether workers' comp would apply, but I'm sorry. Let's say the child got in a car accident, and so there could be some benefits coming that way. It's any other legally liable third party would have to be billed.
Okay, great. Thank you for that question. And on the duplication of services, we'll definitely follow up. I know that that has been an issue that continues to come up in conversations that we have regarding delivery of services in schools, is just that concern about how that coordination would happen. And we are actually planning on doing a webinar in mid-February with your colleagues on the reimbursement side. So it's good we can save some of these questions to revisit with them as well.
Just a point of clarification, Alex, the people who do third-party liability, they're different from our reimbursement staff. So you may want to either piggyback that presentation or get the third-party liability folks separately.
Perfect. Okay, thank you for that.
Yep, sure.
So the next question is wanting to know if you can both speak a little bit to the role of EPSDT in preventive services and early interventions.
Sure. So the role of EPSDT in preventive services and early intervention, is really based at the heart of EPSDT in some ways when it comes to screening and the periodicity schedules. And it's really a benefit that's about identifying hearing, vision, and issues early on to really achieve that preventive aim and to identify issues early before they're exacerbated, especially in our most vulnerable population, which is children under the age of 21. So I think at its heart, EPSDT is really geared towards preventive medicine and identifying issues as early as possible and ensuring that children are meeting all the milestones so that they can grow into healthy adults.
Yep, that's absolutely right. And I will add that you all know about Part C of the IDEA, which covers early intervention services. And that's unlike Part B, which is the IEP program for children aged 3 to 21. This is for Part C, as you know, it's for the little ones. And I love the idea that Part C is specifically designed to meet a child's developmental needs. I think it's been well established that the earlier some children are found to have some kind of a difficulty or delay, the sooner the services are rendered, the better prognosis is for that child. So services, whether or not they're provided in an IFSP, the thrust of EPSDT, as Lindsay said, is prevention. And then there's the preventive services benefit. And then there's early intervention services, again, whether or not states are trying to cover them in an IFSP. We can reimburse for services that meet the Medicaid requirements for the particular 1905A service. Typically, it is going to be under our preventive services benefit.
Great. Thank you, Marguerite and Lindsay. So another question is just wanting to know if you can talk a little bit about the challenges of administering EPSDT and just if there are common problems that you see emerging in your work on this issue, and if you'd be willing to share those challenges with this group.
This is Marguerite. The one I see that I think is most challenging for states is when we removed or withdrew the free care policy. Again, you all know this, and you know it better than us, but we haven't seen states basically breaking down our doors to amend their state plans in order to expand services to Medicaid eligible children in school settings. So most states are still limited to services in an IEP or an IFSP. I'm not exactly sure I understand why that is. It could be part of it has to do with the interaction with managed care plans, and that's the part I'm not very knowledgeable about. But I pie in the sky thinking would be that either states put school services in those contracts and don't carve them out anymore for managed care plans, or the other pie in the sky thing is why don't states just put a practitioner paid by the school and they in the school setting, and then it can be billed either fee-for-service or managed care, depending on what the state's service delivery system is. But I think there's a big hole for states. I think they're not breaking down our doors to do this change because I think it's the managed care requirements they're unsure of. And how do they know services are being furnished and paid for by the managed care plan? That's just a guess. But again, that's a great topic for Susan Ruiz to talk about. And I think there's one more problem. I think practitioner qualifications, I said earlier that we see states somehow having lesser qualifications for the practitioners who are in the school setting. That one's a pretty frequent flyer. We get that issue quite a bit. I can't think of others at the moment. Lindsay, how about you?
No, I was just going to mention, as you did, the difference in the practitioner qualifications between the school and community setting. And just kind of to reiterate, CMS requires that minimally they're the same qualifications for school and non-school practitioners. So as Marguerite mentioned, we wouldn't accept school practitioners that have lesser, if you will, qualifications than practitioners in non-school settings.
There is one more thing about EPSDT, or actually any Medicaid service, but let's focus on EPSDT. Not that it's necessarily problematic, but that this audience should be aware of if you aren't already. Any state plan amendment, we're going to ask for, well, most of the state plan amendments, we're going to ask for, are there any limitations on the amount, duration, or scope of the service? And under EPSDT, there really can't be what we call hard limitations. In other words, it can't say this child only gets 16 visits, period. Or this child only can have this service for 6 months, period. Those would be considered hard limitations, and we would require a state to then demonstrate to us with data how that service meets the needs with that service with that limitation meets the needs of 90% of the beneficiaries who have used the service. So to avoid us sending these kinds of sufficiency questions, generally speaking, you want to put what we call soft limitations on a service. And that would be where the limitation can be exceeded by medical necessity, or the state includes a prior authorization process before they allow additional services beyond the 12 visits or the 6 months. Those are appropriate. But in the EPSDT world, there really cannot be any hard limitations. There might be for adults, but then we would ask those sufficiency questions. We would want to get the data. But for children, it undermines and actually doesn't make sense when children are supposed to get all medically necessary services. So we would not entertain and we would not allow any state plan that said there were hard limits on amount, duration, or the scope of services. What we would allow for children under 21 is what we call the soft limits. And I think I've said everything I needed to say. Did I miss anything, Lindsay, on soft limitations?
No, I think you covered it. My only other thing that I would add is if you're working with your state Medicaid agency or you're in discussions with them, CMS is also available to provide technical assistance if you're thinking about proposing a service and you just want to run it past us and get, feedback. We're happy to do that as well.
And I thought of another issue. We used to get, not so much anymore, but there was another issue about delays. That used to be more common when we were entertaining SPAs that offered autism, ASD, autism spectrum disorder services. Another basic premise of the EPSDT benefit is that services have to be provided without delay. Screening services can't have any delays. If the child, whether or not the child has demonstrated any symptoms, they're supposed to be screened according to the periodicity schedule. And then if they even between the periodicity schedule, they exhibit some kind of a problem or issue, that screening has to be done as well. So screenings don't require prior authorization. Screens cannot be delayed. Services after medical necessity is determined cannot be delayed. Well, what does delayed mean? I think we would interpret delay as anything that is unreasonable, a length of time that is unreasonable. Advocates complained to us that the ASD treatment services that children were needing in this state were being delayed upwards of, 90 days, 6 months, sometimes longer. Well, then we took a look at that. So it is kind of a state-by-state issue, but if it gets to be where the delay in services is something like, months and not just weeks, CMS would probably take a look at that.
Thank you so much, Marguerite and Lindsay. That was, you just covered a lot of really important pieces of information. So I really appreciate that level of detail. We have time for one more question, which is coming back to the duplicate billing. And just so as an example, someone specifically wanting to know if the hearing vision screenings have been done as a part of EPSDT and then separately for a health assessment as a part of a student's IEP, is that something that would be considered duplicative billing?
Can you repeat the question, please?
Yeah, sure. So wanting to know if, if a student receives their hearing and vision screenings as a part of EPSDT, and then separately they're receiving them as a part of the health assessment for their IEP. If they if those were to both be claimed, would that be duplicative billing?
My guess is yes, if, I want to double check, so don't quote me on this yet, but my guess is yes. Well, now I'm gonna backtrack a minute. If the periodicity schedule says a child needs this screen at a certain time or this vaccine at a certain time, that may very well be different than a health assessment for a particular service. Now, having said that, if it truly is, they're being considered for the same vaccination they just had or the same developmental screen they just had, that probably would be a duplication of service. Now, we'll double check on that. What do you think, Lindsay?
Yes, I agree. I was just going to say, if the periodicity schedule, if there's any flexibility in it being a different issue, then, it might not be duplicative. But if they're both, truly just baseline hearing tests or baseline vision tests, and the difference is just the setting that it's occurring in, I would guess that would be duplicative. But as you mentioned, we'll take that back and we'll circle back with our reimbursement colleagues.
And hopefully there would be coordination between the the non-school provider and the school provider, in that any reports from those screenings done outside of the school setting should hopefully be available in the school setting so that you can do your planning for that student. But I don't have a clue on how that coordination is done. I just hope that it's being done. I don't fully understand how schools would communicate and coordinate with non-school practitioners.
Sure, that is certainly a challenge that I know many folks on the webinar have dealt with and are working to address. But we appreciate you raising that, and certainly we will follow up with the questions that you wanted to share with your colleagues, and we'll be sure to follow up with everybody on the webinar today with any additional information we find out about those questions. So we will go ahead and wrap up. We're at the top of the hour. I just wanted to thank Marguerite and Lindsay once again for joining us on today's webinar. We so appreciate your time and you lending your expertise on EPSDT to this group. And we will follow up with everybody again with any additional information we are able to come up with regarding those questions, and then with links to today's slides and a recording. So thank you everybody for joining, and thank you Marguerite and Lindsay for presenting today.
You're very welcome. Have a good day.
Bye, everybody.
Have a great